All right, welcome everyone. It is Tuesday, January 16th, and you're in the House Healthcare Committee. And this afternoon, we're going to take the whole afternoon, or as long as it takes us, for Section 9 of H721. So H721 is an act relating to expanding access to Medicaid and Dr. Dinosaur. And Section 9 is about the Medicare Savings Program. So we're going to walk everyone through, with the help of the Vermont Healthcare Advocate, what the Medicare Savings Program is, and then we'll have additional testimony from various stakeholders. I have 2:15. I have to run and do testimony real quick for a bill introduction, so we'll either take a break or Alyssa or Topper will just keep us going. I shouldn't be gone very long, but we will definitely take a break at some point this afternoon. So Mike, and I don't know if Mike and Emma are coming up together. Do you have two chairs? Yeah, okay.
Jasmine, thank you.
Oh, yes. Is all of that? That's right. I'm up over you. Yeah, I think it's just that.
Aromatherapy for the witnesses.
Ooh, this is great. Thank you. Okay.
Are you ready for us?
Yes, I'm sorry,
No,
I'm sprawling over here,
Literally,
and so I'm just taking my stuff back to my spot. Yes.
So thank you, committee. I'm Mike Fisher, and I have with me.
Emma Zavas.
Welcome, Emma.
Thank you.
So we are happy to spend some time with you walking through Section 9 of the bill. It's a short little section.
It is. It is very important.
Key numbers on it. And so, you want to steer?
I'll steer.
So we always have to put a slide of our team up. And I just wanted to just pause and say, I want to appreciate this room. You guys have been a real supporter of the Healthcare Advocate's Office. It's not by accident that we have a really strong team. And I also recognize, sometimes when you do things legislatively, it's hard to know the impact of it. 2 years ago, you gave us support to increase, to add another position to do consumer research.
Welcome, Emma. We love what we see. We see the end result of our labor.
Tangible results. So.
And Mike, if I can just say, you receive broad support from this group and other legislatures because the work your staff does is amazing. So we appreciate that. When we have, constituents call us and it's about healthcare, we can send them to you and we know they're in good hands. So thank you for that.
Yeah, I'll just say another sentence about exactly that. Have you ever asked me what you thought was a simple question and gotten a really complex answer back? I want to assure you it wasn't me.
Right.
It was these people
yes.
backing me up.
Very good.
So we always start with choice. Emma and I are going to pass back and forth different sections of the bill, of the presentation. Go ahead.
Right. Okay. Well, thank you for having us this afternoon. Let's start by saying that the Office of the Healthcare Advocate has long been aware that Vermonters with Medicare are suffering. They get less financial support for healthcare than any other group in the state of Vermont. This year, we decided to go directly to Vermonters with Medicare to ask how this issue is impacting them. In the fall of 2023, we launched a Medicare affordability survey on paper and also online. We drove all over the state. We visited groups of people with Medicare at 8 different senior centers. We did many one-on-one individual in-depth follow-up interviews. And the stories we heard were powerful. And we knew that they should be shared. So we have created a Medicare Stories webpage featured here. We're rolling it out this week. It features 5 stories of 5 different Vermonters, all of whom have Medicare and are struggling with their health insurance costs, struggling to access care, and struggling with even basic expenses like food and housing. So we hope that tonight or this weekend in the future, you'll get a chance to spend more time on the webpage, reading everybody's story. But now we will play an audio clip or two to just give you a taste. Bear with me as I change mediums. So the first story we have is going to be Sandra.
Premiums are more with much less coverage. I just don't go to the doctor anymore because of the deductible and co-pays. I never know what they will be, and I just can't take the chance. We had a copay, and it was a $20 copay. So if you went to the doctor, it would be $20. But now I don't know how much it would be if I went to the doctor because of the copay and the deductible, and then Medicare only pays 80%. I don't feel like I can go to the doctor not knowing how much it's going to be. Pass out or something. Think about how an ambulance don't just let me die because we can't afford it.
Let's do a sound check. Could people hear that?
Barely.
Is
Okay.
there a way to get it?
Is there a way to,
You and the
Is
Zoom?
there, wait, can I increase it on here, the volume? No, it's supposed to be for computer. Oh.
Setting where you put the audio through Zoom instead of.
No, but I think she didn't want us to do that.
yeah, because of echo
Oh.
action.
Look at that.
Come on, thank you. Let's see if these work.
Yeah, he's ready.
Very prepared. I love it.
There's your remote, I can film.
Nope. No. That looks promising. There's something over there. Something there. Okay, should I try it again?
Do it once.
Yes, let's do it again.
You want to do that one again?
Sure. Only 45 seconds. We'll give it another try. Okay.
Premiums are more with much less coverage. I just don't go to the doctor anymore because of the deductible and co-pays. I never know what they will be, and I just can't take the chance. We had a copay, and it was a $20 copay. So if you went to the doctor, it would be $20. But now I don't know how much it would be if I went to the doctor because there's a copay and the deductible, and then Medicare only pays 80%. I don't feel like I can go to the doctor not knowing how much it's going to be. If I pass out or something and you think about calling an ambulance, don't. Just let me die because we can't afford it.
All right, so hopefully you could hear that a little bit better. That was Sandra. Sandra lives here in Vermont. She has Medicare only. Her income is too high to qualify for Medicaid or the Medicare Savings Program and way too low to afford a Medigap plan. So she just has Medicare and is trying to make it work. This next story is for...
When you say Medicare, I'm sorry, is that just Part A or Part A, Part B? What do you,
Part A, Part B, and I believe she has a drug plan as well.
so that's what you're thinking?
Yep.
Thank you.
Yeah, we'll get into those costs. All right, one more story I'll share quickly is Jamie, and this is the story of Jamie and his wife Linda. We'll just do part of this.
Of being dropped from the I-1 program, the medical savings program, that costs us $330 a month, and then the both of us, and then with the rent increase we had March 1st, there's $135 more a month. And everything else as far as economics wise, groceries and things like that, and medicines and things, away in a awful hole. So a lot of stuff now we get to have to use the credit card. Problem.
Jumps into another story, also healthcare related, and you can listen to the rest of that.
And you said this is all on your website?
All on the webpage. We'll make sure to send that out to folks. So Jamie and Linda used to have the Medicare Savings Program. It used to help them with their Medicare premiums. They got a Social Security cost of living adjustment, and now they are $18 over the income limit. And they no longer have the Medicare Savings Program, so they are struggling.
So one of the risks when you bring stories to the legislative table, to the policy table, is that it's easy to think maybe they did something wrong. Maybe they didn't make the right choices. And so this slide is really to make the point that this is a structural problem. If you have years of low wages, year after year, those low wages compound. By the time you're in retirement, you haven't had enough money. You haven't been able to tuck money away. You haven't had the earnings to get a decent Social Security payment. And so the impact is a structural impact that that we have a lot of poverty for people in retirement. Now, it doesn't take a rocket science to figure out that there's certain groups that are hurt more than other groups. There's certain groups that get lower wages. And so this slide is really to make the point that that women, people of color, people living with a disability don't have access to the same wages for the same work. And that results in a disproportionate number of the people in poverty in Vermont being from those groups. And we have a couple statistics here for women. Women earn get Social Security benefits that are 59% of men. And the result of that is that 44% of Vermont women senior women don't have enough income to make ends meet. Just take a second to look at the chart, the map chart there. I'm interested and don't know why it is that in Addison County, I don't know what we're doing right, Mari, Representative Cordes, that women earn 8.5% less than men there, whereas just up the road in Chittenden County, women are earning 20% less.
And you'll eventually connect the lower Social Security benefits with the MSP program.
Yes.
Correct? Okay.
So,
All right.
Correct me if I'm wrong, but if you're filing, if you were married and this happens with me, my spouse makes less than I do in Social Security because of whatever. But upon my death, she would get my Social Security benefit. Yeah. So is it fair to say married women would be a lot of that figure?
Yes and no. I mean, that's true. So if a spouse dies, whoever's Social Security benefit was higher is the one who the surviving spouse would take. But you don't have you don't have two Social Security incomes coming in anymore.
I understand that. But when you throw the statistic out, it can be deceiving because married women who benefit from their husband's Social Security get less than the general course.
Yeah.
Just so we know what we're looking at here. Thank you.
Well, can I ask?
Can
I ask about?
You can ask a question. You cannot do it, but you can ask a question to clarify. Okay.
Would it be true? I'm just thinking through that the women have less Social Security because they earn less than their lifetime.
yeah.
Yes. Yes.
Yeah, and it's both the wage gap and it is our social patterns. Who takes time off of work to care for kids? Who takes time off of work to care for elders? Who takes time off of work to care for their partners? I mean, we have certain patterns, and that plays out, resulting in women having less earnings.
All right. So next, we're going to dive into this big, wild question. What is Medicare? And Mike and I could talk to you for hours about what Medicare does and does not do for Vermonters.
Right, and let me set the stage too. We are going to look at Medicare in regards to Medicare savings plan. We
Yes.
are not looking at the whole Medicare.
And
Oh, no.
and that's exactly what we were going to say.
Yeah, so we are flying high. Thank you. Perfect segue. So I have two short slides where we're going to do a baseline and then we're moving into the Medicare savings program. So what is Medicare? Medicare is a health insurance program for Americans who are over age 65 or disabled. In Vermont, in December 2023, approximately 130,000 Vermonters were on Medicare. Big chunk of the population. Most people think that Medicare's free. You worked, you paid into the system is now going to take care of you. Unfortunately, that's not true. Medicare is not free. And we're just going to walk through the three major parts of Medicare and the associated costs quickly. So the first one we have there is Part A. Medicare Part A is your hospital insurance if you have Medicare. There's a $1,632 deductible if you have an inpatient hospital stay. That's per benefit period. So you could go back to the hospital the same year and have to pay that again. There are also co-pays and cost sharing for many services. Medicare Part B is your medical or outpatient insurance. There is $174.70 a month premium that comes out of your Social Security check every month. That is more than $2,000 in a year per individual. There's also a $240 deductible before you start receiving any payments for Medicare for services. And there's 20% cost sharing for most services, and that adds up very quickly. Finally, with original Medicare, there is no out-of-pocket limit. Your costs can just keep going. The last major part of Medicare is Medicare Part D. This is your prescription drug coverage. In 2024, the average prescription drug plan premium was $66 a month. Some are lower, some are much higher. The range in the annual deductible before insurance starts covering things is $0 to $545. So if you buy a plan that has a very low premium, you're going to have a huge deductible. Plus, all the plans have co-pays, major cost sharing for drugs, and there is no coverage in the infamous coverage gap or the donut hole. So if your costs get to a certain point, your plan stops paying for a while. So all of this is to say, Medicare is not free. Turn it over to Mike.
So first off, let me just say, as is true with almost everything in Medicare, it's poorly named or sometimes has multiple names just to confuse you. The Medicare Savings Program isn't Medicare, and it's not a savings program. Just to throw you off your...
Surprise.
It is designed to wrap around Medicare. It is a Medicaid-funded program with a state federal match. Well, we'll get into some details. Much of it is funded with a state federal match. Some of it is funded with straight federal dollars. It is designed to wrap around Medicare and help lower income people be able to afford their premiums and in some cases their deductibles. A little over 26,000 Vermonters were on MFP programs, according to the Act 99 report, and I did just grab a copy of it. Not gonna spend any time on it here, didn't make copies for the committee or anything, but 2 years ago, Department of Financial Regulation did a fairly in-depth study about many issues related to elders in health coverage. And if you are just teased by our presentation and want a much deeper dive, I would recommend it. Go ahead.
All right.
So you'll hear MSPs described in three different programs, but we're just going to sort of on a very high level say there's two categories. One of them is commonly referred to as QMB, Qualified Medicare Beneficiary. I'm going to say we should do a little quiz. Who can guess the acronyms here? Currently in Vermont, if you earn less than 100% of the federal poverty level, that program supports your Medicare premiums and your copays. So it's Medicaid-like. It's not identical to Medicaid. There's a few things that are different, but substantially it's full coverage. If you earn today just a little bit over that, you qualify for one of the two other programs. From the consumer's perspective, they look the same. They cover Medicare premiums, SLIMD and QI1. And so I'm not going to go into they have different income eligibilities and they're paid for in different ways. But that's the Medicare savings program. I don't really know if I like this question here, but go ahead, let's go to the next one. What have we left behind? So over the years, this committee, the federal government, there's been a lot of work to improve access to healthcare. In our years of focus on the healthcare watching the healthcare landscape, we've always recognized that older and disabled Vermonters get the least amount of financial support. The Affordable Care Act played out a little bit differently for Vermont, but for the nation, it created a higher level for the Medicaid program that serves people who are under 65 and not disabled. And so it brought it up to 138 for most states. A few states persist in refusing to do that. But it also created a process whereby someone who earned just a little bit more got financial supports to be able to buy insurance.
Mike, we're just gonna need you to speak up a little bit when you talk.
Okay.
I don't know.
So that goes to about $30,000 for a household. On the other hand, the Affordable Care Act didn't touch, nor has any other policy area touched, the Medicaid programs that support people who are disabled or over 65. And so, I'll just say the labels here. MCA, the under 65, is Medicaid for children and adults, the dark green on the left. And the dark green on the right is MABD, Medicaid for the age, blind, and disabled. And the MSP program is what we have that goes just above the Medicaid level and brings people up to 100% of the federal poverty level, or about $20,000 for a family of two.
And just to clarify, so the MABD, Medicaid age, blind, and disabled, is that 65 plus and disabled group that we are talking about with this program.
So this is what we've been calling the Medicare cliff. You can have the same income, the same family size, happy birthday, you turn 65, and what you get for that is losing Medicaid, is you losing financial supports. And we hear from people all the time, regularly, who say, OMG, what happened? I thought I had Medicaid. I qualified for Medicaid. What happened? Well, guess what? We haven't touched the Medicaid supports for people in that next category.
All right, so can Vermont expand its Medicare savings program? Yes. I love giving that answer. So Medicare is a federal program, but states decide how much financial support folks with Medicare get. So Vermont has the ability to change one or both programs that lower Medicare costs. The first program is Medicaid for the aged, blind, and disabled. So that's different than Medicaid for children and adults, Dr. Dinosaur, that world. This Medicaid for aged, blind, and disabled helps people, it works with Medicare to help lower their cost sharing of the doctor and hospital to $1 or $2 of a The other major program is the Medicare Savings Program. So this helps lower people's Medicare cost sharing. It's actually, I think, $0 when you go to the doctor or hospital. And it also pays their Medicare premiums, which is a huge cost to folks. And that's why the Office of the Healthcare Advocate thinks that you all should focus on expanding the Medicare Savings Program first.
Number one.
Yes.
Medicaid for the aged, blind, disabled. So somebody that fell in that category would have both Medicaid and Medicare?
Yes. Yep. Yeah. So your Medicare would act as your primary insurance.
Medicare would be.
Medicare. Yep. That'd be your first first line of insurance, you
Okay.
put that card on the table.
Yeah,
Then, if you don't have anything else, then you pay out of pocket. If you have Medicaid for the aged, blind, and disabled, you put that card on the table, they bill the rest of it Medicaid.
so this is anybody over 65?
And below a certain income level, very low.
And below or below? and below.
Yep,
Okay, 65 and below a certain income level, and blind and disabled?
no, so this is a program, so if you are over age 65.
Yeah,
And you would have Medicare, if you are blind or disabled through Social Security Administration, the 25th month of your disability, you get auto-enrolled into Medicare. At that point, the state will look at you in terms of this Medicaid program, and they'll apply the MABD rules to you.
okay.
So it's a very low income threshold, and there's a resource test that's very
It's
restrictive.
and just say, it is deep poverty, is very
Yes.
low income.
Right, I understand.
And-
Yeah,
And the resource test is significant.
I'm just trying to understand how it
Yeah,
works. So
yeah, those are great
Medicaid
questions.
care goes in and then Medicaid picks up the rest. So
Exactly.
out of pocket for these folks is nothing?
If you qualify, yes.
If you qualify,
But not many
right,
people
okay.
qualify,
Yep,
but
yep.
yes, yeah, that's
Okay.
how it should,
Yep.
would work.
Yep.
Good
I have one more
questions.
question, Lisa.
Maybe I'm getting ahead, but
Yep.
I'm thinking about costs here.
Yeah.
So you're 64 years old, you're at 149% of the poverty level.
Yeah.
Essentially, you have Medicaid.
Mhm.
You've got a
Well,
per
no, not
member.
149%.
You've got,
You
okay,
have a Silver 94 plan through Blue Cross or MVP, very low premium because you're getting awesome premium tax credits on the exchange, very low cost sharing.
and low cost sharing. Okay, well, let's go with 136% or
Sure.
35. And you're on Medicaid.
Yeah.
What's your per member per year cost for Medicaid? And I'm thinking, you hit 65, all of a sudden you become really cheap. Because essentially Medicare is picking up almost everything. So what is, like, somebody on Quimby, what is their per year cost to Medicaid?
Yeah.
Yeah, it's a good question.
Versus somebody who was 64? Oh, we don't know that?
No,
I don't know that off the top of my head, but it's a great question. And we can do some research later.
But I hear where your head is going.
Yes.
It's gotta be cheap.
A significant portion of it is federally funded.
Yeah.
Once you're on Medicare.
So you're saying the cost to Medicare is cheaper,
To Medicaid.
to Medicaid is cheaper. You're not talking about the cost to the person.
No, not to the person, because my Medicare, other than your deductibles, your 80%, your other cost sharing, Medicare is picking up that. You're basically just paying that $174 premium every month for the person, plus
And when you say you, Medicaid.
Medicaid is paying the Medicare premium of $174 a month, plus they're just paying the cost share. So that's gotta be a lot cheaper than paying 100% of that person's.
Yes.
Okay, that's, okay.
So I want to make sure everyone understands that, what she's saying. So, because I don't want to confuse what Alyssa's saying about cost with the cost to the person. So Alyssa's looking at the programs, Medicaid and Medicare. And so you're on Medicaid, Medicaid insurance is paying for all of your health care. You turn 65, you go to Medicare. Medicare is now paying for your health care. So the dollar cost associated now with Medicaid for the wraparound of these programs is less than what they were paying for the full health care of that person that was on Medicaid insurance. And then when you look at the person is getting covered by Medicaid insurance, they turn 65, they go to Medicare, their cost out of their own pocket goes quite high. Okay. Did I say that right?
Yes, and I'll say the one caveat is that as people age, they tend to need more healthcare, so they're going to the doctor more. So the savings to the system aren't always, generally speaking, yes, but you're also, as you're aging, maybe going a little bit more. You may need more tests, that kind of thing. All right, so This is still me.
Yep.
All right, so those are the two major programs that the state can have an impact on in terms of changing the eligibility levels. Many states have already expanded these programs, and Vermont has significantly fallen behind. The last major national healthcare reform was the Affordable Care Act, and as we noted, it really left folks out who had Medicare. So states have stepped into the void. On the left, you can see states that have increased the income limit higher than Vermont for the Medicaid for the Aged, Blind, and Disabled program. Leading the pack are California and New York at 138% FPL. There are a couple of states that have no asset test, and then there are a handful of states that still have an asset test, but it's much higher than the federal minimum. Vermont's asset test is still the federal minimum. That's $2,000 as an individual or $3,000 as a couple.
Can you explain what an asset test is?
So an asset test will look at your checking and savings accounts. It will look at your retirement, anything like that. So if you have $4,000 in the bank, you do not qualify for Medicaid. So
You do not qualify for these programs.
for the Medicaid for the Aged, Blind, and Disabled program in
Okay.
Vermont.
Okay.
Because the fourth,
And just to be clear, there is no asset test in Vermont. That's one thing that we did do. There is no asset test in Vermont for the MSP program.
Okay. So for Medicaid blind and disabled, Medicaid age blind and disabled, if you have more than $2,000, you do not qualify for that program at all.
$2,000 for an individual, $3,000 for a couple.
And so as your life goes on, if by some unfortunate circumstance, you now have $1,000, can you then apply for it? Or is it
You can certainly apply at any time.
Okay.
But the asset test means that you need to be living in deep poverty, about a step or two away from, an eviction, basically. You don't have any savings to speak of. Medicaid for children and adults, Dr. Dinosaur, there's no asset or resource test for those programs. You can have, any amount in your checking and savings. But the rules change when you come here.
okay, so Mari and then
Go ahead.
Leslie and then
So
Melanie.
for both MABD and MSP, if I am 69 and I'm a seventh generation farmer living in my rundown farmhouse on however many acres, does that count as an asset? So I have very little income, but I have this house.
Property.
Yeah, usually there are exceptions for things like that. So if it's your business that's your source of money, there's an exception. Or if it's your property, like the home that you live in. If it's a second home, it counts as an asset.
Your own
There's
home
very
does not.
extensive rules, but yeah.
Your own home does not.
Your own home does not. No,
Okay.
you don't. Yeah, it's a good question. Yeah, thank you.
Leslie?
So the asset is determined at the federal level or at the state level?
It is set, it is suggested, I guess you could say, by the federal government. There's a federal minimum. And all the states that are now on this list have the federal minimum, including Vermont. So we have not done any work to increase the limit or eliminate the limit.
So can we eliminate that asset test?
Absolutely, yes. Yes. And many states have a much higher asset test. It's 30,000, it's 50,000, whatever they decided. And two states, Arizona and California, have eliminated it altogether.
But I want to just go back one slide and say, when we look at this landscape and we look at the possible steps available to you, we land on taking the step that's in section 9 of the bill about MSP program. We didn't land on improving the MABD program. We'll come back next year because we think that needs to be addressed, but we're not suggesting that you take that action this year.
I will say that states are, in tandem, they are working on one and then they're working on the other. So they're working both programs. Some of them decide to do MSP first. Some of them attack MABD. It all depends, but ultimately, improvements to both of the programs are ultimately needed. Our focus today is the Medicare Savings Program. So,
Hold on, we still have a couple questions.
oh yeah.
Melanie and then Art.
Just making sure that I understand, maybe I don't, but if remove an asset limit, increase an asset limit, or increase an income limit, that helps to decrease the cliff, is that correct?
Yes,
Okay.
yep,
Yes.
definitely.
Yeah, sure, I understand.
You're good.
All right.
We'll have some charts to show that, that cliff disappearing. You're on track. Yeah.
All right.
Yeah, and that wasn't my question, but to make sure I do understand.
Yeah.
So the asset limit's high, that means that what?
The asset limit's low, which means that in your bank.
You don't
account-
have much money.
Right, it means that you have to have almost zero money in the bank in order to get Medicaid help.
Okay.
Yeah.
If my assets level's high, I don't get that.
Yeah,
If
exactly.
you remove the limit,
Yeah,
you could have a lot of money in the bank and still get it?
you could. And that is the case for Dr. Dinosaur and Medicaid for children with and adults. There's no asset
So
test
you
for
could
those
literally
programs.
win an award of some kind, a property split up, a family inheritance.
You
Put that in the
technically
bank and you could benefit from somebody else's tax money coming to you.
Technically,
Okay.
that is true.
All right.
Yes.
And we're not suggesting that.
No, we're not. Yes.
No, but it
Yeah.
We'll fight
is,
that battle next
yeah,
time.
okay, yep.
Okay.
Medicare savings, Medicare savings programs on the right. Those states have increased the income limit above the federal minimum, and several states have eliminated the asset test, including Vermont. So that's great. Go ahead. We're going to look a little bit further at the states that have increased the income
It
limit.
just so happens that our neighbors are the states that have taken action. Most recently, Maine, just last year, and the year before, New York, increased their MSP programs eligibility. And, in this chart, it looks like Vermont is all by itself. The reality is, there's 5 states and DC here. So Vermont is with the other 45 states that have not taken this action. But nonetheless, our neighbors are taking this action to draw down federal dollars to support these low-income people.
And so can you just explain so everyone understands what the chart is saying?
So you can see under the QMB line, the QMB line, and that's the level, again, that pays for low-income people's Medicare premiums and copays. That these states, DC is, the crazy leader at 300%, but Connecticut, all of these states have at least raised it above the Medicaid level, the MCA Medicaid level. And then the 2 charts on the right, SLIMB and QI1, both of them pay Medicare premiums. And so you can see Maine, I think now is the leader, right? At 250% federal poverty level
They just did theirs last year, right?
just last year.
They did. And all of these changes have been approved by the federal government. Maine's is still pending because they just made the change in the legislature. But everybody else has gotten a stamp of approval.
Meaning they've also drawn down more federal funds.
Yes, absolutely. All right.
Let's talk about now.
Yes, perfect segue. All right, so I'm going to talk a little bit now about how the funding works on the back end. Not going to go into a lot of detail because I know that Danielle Fiocco from DIVA will be talking to you later today about that. But at a high level, so when a state expands their Medicare savings program, they have to expand all levels. So you can't just expand the level that's fully federally funded. We wish. No. So instead, let's focus on the first row. That's the qualified Medicare beneficiary program. Again, that's the one that helps with cost sharing and your premiums. That is a traditional federal state split, a Medicaid split. It's that FMAP. So are some state dollars there to get that federal match. The next row is the qualified individual program, QI1. So that's the program that pays for people's Medicare Part B as in boy premium. It's worth about $2,000 a year to people. Otherwise, it comes out of your Social Security check each month. That level of MSP is 100% federally funded. So that is money that we are essentially leaving on the table right now that New York, Massachusetts, Maine, all of these states are taking advantage of. So the last row is the low income subsidy program, extra help. And we haven't talked about this yet before. So this is a federal drug program. And one neat thing about the Medicare Savings Program is that if you qualify for the Medicare Savings Program, no matter if it's QMB, QI1, whatever level you are automatically deemed eligible for this amazing federal drug benefit. It pays your Part D or drug premium for Medicare. It lowers your copay significantly. It can waive late penalties if you came into the program late, and it provides coverage in the coverage gap or donut hole. That is also 100% federally funded benefit. So there's a lot of federal funding out there. Go ahead. Did you have something?
Yeah, I was just going to say that with a minor adjustment that we're going to suggest in a minute about the language that's on section 9, our proposal is designed to draw down federal dollars. That's what we're trying to do. It's going to take some state dollars to do it. Let's not pretend that it's free to the Vermont taxpayer. It's not, but our goal here is to improve low-income people's access to care. But it is also to draw down federal dollars to support that.
Just a question on that chart.
Yeah.
If those two situations are federally funded, why do we need to do anything with them? Wouldn't they automatically?
Yeah. So we do get the federal funding for those, but we have kept the income limit for which Vermonters can qualify for the program at the federal minimum.
Okay.
So if we increase it, more Vermonters will get to access that.
And does the feds take this, look at it and approve it? Is that what it takes?
Yes, the feds are approving it.
Okay.
New York, Massachusetts, Connecticut, they're all approved and they've been getting the money.
But in order to do that, I think you said we can't just increase those two programs. We have to increase the one that requires state dollars.
Okay,
Yeah.
all right, they all come together.
Right.
They have to come
You gotta give
together.
a little to
Okay.
get a lot. But
Yeah.
yes, those are great questions. Okay, so when we're thinking about program costs, and again, I think hopefully Diva will go into more detail later. I also want us to think a little bit about the potential savings. So everyone who qualifies, as I said, for the Medicare Savings Program is deemed eligible for the federal LIS low-income subsidy drug benefit. That's great. And it saves states like Vermont, hopefully would save us money. Other states have experienced savings to their state pharmacy assistance programs. So in Vermont, we have a state pharmacy assistance program. It's called VFarm. People pay a premium to the state, and the state turns around and pays their prescription drug premium, and it helps lower their copays to an affordable level. So we have that program. VFarm's awesome. It does great work. Lots of people are enrolled in it. The state of Vermont requires that everybody who's enrolled in VFarm apply for the federal LIS program. Because everybody who qualifies for LIS, the federal government pays for almost all of their drug costs. So it's kind of transferring some of that cost onto the federal government. The thing is that at the federal level, the LIS program has a resource test and has its own income test. So some people on VFarm qualify, but some people don't qualify because of the federal tests for LIS. The amazing thing about the Medicare Savings Program is that you get to skip those tests. It just magic wand makes you eligible for the federal LIS program. So we are hoping that Vermont, like many other states who've expanded their Medicare Savings Program, will see significant savings. New York projected, this was 2 years ago, so they're just sort of seeing the results now, but they estimated that it would be budget neutral to expand their Medicare Savings Program, and they would save, I think it was an anticipated $2 million to their state pharmacy assistance program. So the caveat is that each state designs the state pharmacy assistance program differently. Some have premiums, some have deductibles. So it's not apples to apples. It's not a guarantee, but it's something that the state should definitely look at to understand that this might be a source of funding for expanding Medicare Savings Program. Benefits all around.
So if we fund VFarm for general fund dollars, we could potentially have a savings there that we could then do our state match to expand MSP.
Yeah.
And while doing that, the Vermonter is still receiving the drugs.
Exactly. And they're getting more benefits for their Medicare than for everyone.
With one caveat, we fund V-Farm with general fund dollars and premiums.
And premiums. Okay.
So if you're a budget writer for the state, you're looking at the loss of those premiums as a bad thing. If you're a low-income advocate, you're looking at very low-income people having to pay even just $15 or as much as $50. And so we would be replacing those premiums with federal dollars. That might result in somewhat less savings to the state, but it's still savings for Vermont.
And may mean that some Vermonters who are not getting the drugs they need to be healthy would be able to start receiving the drugs they need to be healthy.
Oh, yeah, thank you. It means people getting care.
Yeah, exactly.
So it's always our goal.
Yes.
Okay.
Oh.
Let's see that. Oh, proposal. Sorry, the Zoom screen at the top is covered. There we go.
So that's what's in section 9. Bring Quimby up to 150. I want to recognize that I think we may need a technical amendment because we are not actually eliminating SLIMB. It is being subsumed by Quimby. So we may need to restate that. And the proposal that's in section 9 has bringing QI1 up to 185. We have a suggested amendment, which is to simply change Quimby, QI1 to 225.
They're saying 185 is not that high.
So all of these numbers are too low. Every single one of them, we should be raising significantly higher. But the reason why we're suggesting 225 over 185 goes back to the State Pharmacy Assistance Program, V-Farm. V-Farm currently maxes out at 225. And so if we brought QI1, if we were able to bring QI1 with federal approval up to 225, we would be taking the entire V-Farm program and making them at least eligible for the federally funded extra help.
Leslie.
Thank you. I'm not sure you can answer this, you probably can't, but I've been thinking over the weekend after you're reading this, looking at these levels, poverty levels sound really low. And I'm just trying to understand, and you may not know, where this comes from. Why this number? Why 135%? Why, it's trivial. I mean, well, it's not trivial to some people, but you know what I mean? It's just minuscule. So I've been worrying about that.
I don't know, and you're right. It kind of goes to the same thing I just said. All of these numbers are too low. You know, the frame of our proposal is both to bring down federal dollars and also to at least bring people up to the, you know, the other Medicaid programs. But you're right, they're too low.
So if I may, other states are there states that are way more that we could learn about, or are these the other states' numbers too?
Yeah, so we can go back. Do you want to go back to that?
So I know you mentioned other states, like here on, you know, Maine 185. I mean, it's still low. I mean, it's.
Yeah, it's still low.
I was just gonna say, I think what we need to table that, and we need to learn from DEVA what the cost of this program, these changes would be to the state.
I appreciate that. And also I hear from constituents, right? And they're suffering. So I'm just bringing that suffering for the moment.
Hold on, Alyssa. Sorry, Michael.
Well, sort of to Leslie's point, I've been thinking about this. I mean, why not just raise V-Farm to 250 and then ask the feds to raise this to 250? Why 138, 135? Why? Well, I mean, ultimately, why don't any of these categories at any lifespan have differing income levels? I mean, if we're saying you deserve this at this income level, but 10 years later, we don't think you deserve that anymore. I mean, shouldn't we be trying to get to a point where we're aligning all of our various aid categories across the spectrum
So what I hear you saying is that,
and all to the same levels?
what I hear you saying is that it doesn't look like this system is rational.
Healthcare system.
Here first.
And you're right.
I mean, because we have lots of other proposals within the same bill. I mean, ultimately, if we're gonna start making tweaks around various programs, be trying to get our tweaks all moving in the same direction so that they all ultimately end up in the
Yeah.
right places.
Yeah, is it California? I believe California has their Medicaid for age blind and disabled set to 138% of the federal poverty level, so that it's a smooth transition from Medicaid for children and adults, which is 138, to Medicaid for the age blind and disabled. So yes, I think that there are administrative savings, in terms of the system and in terms of patients. Obviously, it's 1,000 times better to have similar income limits. We have suggested that the Medicare Savings Program go higher than 138 because we think 138 is too low. But also on the Medicaid and children and adult side, they have advanced premium tax credits. They have other financial supports that are available to people with Medicare. People with Medicare cannot go on Vermont Health Connect and get premium tax credits. It's a hard cutoff. You don't qualify for MABD or Medicare Savings Program, there's nothing.
So I think a moment ago, I was hearing this, like, well, can't we get rid of the cliff? Almost like you wanted to visualize getting rid of the cliff. So
Yay!
wouldn't it be nice if it was as easy as that? That's the outcome of the bill, of the language we have in front of you. That's what we're trying to do, is get rid of that cliff. So we've been doing some work, talking to lots of people. And the first one I want to recognize, did you know that there's a Medicaid and Exchange Advisory Committee? Did anybody here know that? There's a few of us in this room who spend time in that meeting every month. So we brought a motion to that committee. This is advisory to the commissioner, to DEVA. We brought this motion to the advisory committee, and the advisory committee just last month voted unanimously in support of this work. We've also done a decent amount of talking with folks also around this room to see who would support this move. And here's the list of people who spoke up and said yes. There's others that are actively considering it. And so I think the list will grow. And there's others I just want to recognize. I reached out to Blue Cross. Blue Cross said yes. I didn't reach out to MVP. I think MVP would say yes. I just haven't done it. So the AAAs, who's going to speak to you later, Disability Rights, Vermont Legal Aid, that's us. AARP, Vermont NEA, the Alzheimer's Association, who's in the room, League of Women Voters, Vermont Workers Center, Vermont Businesses for Social Responsibility, Bi-State Primary Care, Vermont Association for Hospitals and Health Systems, and Blue Cross, who's also in the room, is the coalition in support of this section of the bill.
Any idea, Mike, the QMB up to 150% poverty level, how many people that involves in the state of Vermont right now, roughly? I mean, I know you can't quote a figure, how much it'll cost.
I don't need to put Danny on the spot, who's speaking later to you from DEVA. We need to get those numbers. I've heard estimates, but I think it makes sense for me not to put numbers out there.
I'd like to know that, certainly.
It is many thousands of people. So just to recap, we're addressing an economic injustice. We're saving people real money, $7,000 just in Part B and prescription drug costs. on top of that is all of the copays that would be picked up. We're trying to give people more dignity, giving people at least the dignity of getting the care they need as they're in these income levels, and drawing down as many federal dollars as we can. Right now, we're leaving federal dollars on the table. Finally, another beautiful picture of our team.
Any other questions? None. Okay, so now we're gonna move on to,
Topper, excuse me, one more thing. I hand this out every year. You may have one on your desk already. You can throw it away because it's outdated. This is a cheat sheet that we use that may be helpful in this conversation or throughout the whole consideration of this bill. It has income limits for and descriptions of all of the state Medicaid programs. Thank you.
okay, thank you.
Thank you.
And now we're gonna move on to,
Can I ask one more question? I'm sorry. It's being annoying. Mike seems to be having it. I think I heard what you said. Wait, never mind. I'll ask you another time. Well, I can pick one.
okay, we all set?
Thanks so much.
This is,
And now we're gonna move on to Mary Hayden and Sam Carlton, and they're going to testify in unison, is that correct?
Not exactly in unison. I'll go first, and then I'm going to give some background and about the AAAs and the SHIP programs involved in this, and then Sam has some more real world examples that we hear through our SHIP counselors from clients. Okay.
Go ahead.
All right. Thank you so much. My name is Mary Hayden, and I'm the Executive Director of the Vermont Association of Area Agencies on Aging. Thank you so much for inviting me to testify on H721 Section 9 about Medicare savings programs. And I'm here, as I said, with our state SHIP Director, Sam Carlton. So just to give you some information about us, we are an association representing the 5 area agencies on aging located in Vermont. And our mission is to provide advocacy, leadership, and a voice for Vermont's aging network. AAA services include Medicare and health insurance counseling and education, and that's called SHIP. I'll talk a little bit more about that in a bit. Meals on Wheels, long-term care case management, caregiver support programs, just to name a few of our services. We are serving Vermonters 60 and older, and we are allowed to provide some services to adults who are disabled and under 60. So the SHIP program, first of all, that stands for your local state health insurance assistance program, which provides unbiased help to Medicare beneficiaries and caregivers. So whether you are new to Medicare, you're reviewing your plan options, or have questions, the SHIP program can assist you. In Vermont, the program is administered through our local area agencies on aging. We typically serve throughout the state about 7,000 Vermont beneficiaries every year through the SHIP program. And I should also state that we have a statewide helpline for people to call if they need assistance about their Medicare. So just going over to Medicare affordability, and you've heard some of this already, but just to reiterate that many of us mistakenly believe that Medicare is inexpensive, but it can be very costly for many people. The Part B premium, as you heard, is about $175 a month, but there are also other costs like deductibles and coinsurance and copays. You pay 20% of the cost of covered services. The Kaiser Foundation estimates that half of Americans who are over 65 with incomes below $29,000 a year cannot afford their Medicare. 1 in 4 of those folks are living on less than $17,000 a year. And marginalized groups are disproportionately affected by these uncovered costs. And as Mike mentioned already, particularly women who have historically been underpaid, worked part-time or left jobs to care for children and older loved ones, diminishing their savings, pension, and Social Security incomes. And women live longer and are more likely to live alone when they are older. This disparity increases for women of color. SHIP counselors and providers sometimes see beneficiaries refusing medical treatment to avoid these uncovered Medicare costs. This leads to poor health outcomes, which may result in more costly medical interventions for Vermonters, such as hospitalizations, emergency room visits, and residential care admissions. This is taxing our already stressed healthcare dollars. SHIP counselors, hospitals, and providers are seeing increased medical debt among Medicare beneficiaries. These costs get passed on to hospitals and providers, so we all pay higher premiums. So the Medicare savings programs are available if you have limited income. You may be helped by these programs. And as stated, and it's so confusing, it's a Medicaid administered program, but it's available to Medicare consumers. And as stated, if you qualify, the program can pay for Medicare Part B premium and other cost-sharing expenses, depending on which program you're eligible for. However, because of Vermont's qualifying income level, many low-income Vermonters do not qualify or become disqualified with slight income increases. Some enrolled in Medicare savings cannot obtain low-wage part-time employment without losing their MSP eligibility. This does not help us resolve our workforce shortage in Vermont. We're noticing many Vermonters turning to Medicare Advantage, a private market Medicare plan that may work for many, but Medicare Advantage plans, as advertised, may seem lower initially, but there can be some unexpected uncovered costs. And all Medicare Advantage plans have copays and insurance. And some may have in-network provider requirements so that people may lose their preferred primary care physician and other providers. Travel to in-network providers may be prohibitive if you do not drive and have no public transportation, which is often the case in Vermont. Medicare Advantage plans can impose covered restrictions such as prior authorization, quantity limits. They can require less expensive prescriptions than the one you were prescribed. And many providers are not accepting Medicare Advantage coverage due to payment restrictions. So we're seeing this problem with affordability drive more people into the Medicare Advantage market, which is great if it works for you, but it's not always working for many of our Vermonters. And we do encourage folks to contact the SHIP program if they're thinking of enrolling in a Medicare Advantage plan, because we can provide them with neutral information about the impact of signing up for or changing to a Medicare Advantage plan. And as stated, a handful of states have passed legislation to increase their Medicare savings program income eligibility requirements and enroll more people in MSP. And you saw the corresponding advantages to our funding picture. Age Strong Vermont, our new multi-sector roadmap to becoming an age-friendly state, recommends increasing Vermont's eligibility limits for Medicare savings programs. Currently, there are 26,000 approximately Vermonters enrolled, and if we expand income eligibility, we can qualify many thousands more, again, depending on the new federal poverty limits we decide to adopt. Thank you for the opportunity to testify today, and please feel free to contact me with questions. And I do want to turn to, if it's okay, Sam Carlton, when you're ready, can provide some examples of what our SHIP counselors are seeing in terms of the impact on affordability and financial security of Vermonters.
Thank you.
Hi, everybody.
Before you start, are there any questions that we have? No? Okay. Go ahead, Sam.
Hi, my name is Sam Carlton. I am the Vermont SHIP Director as well as the Care and Service Coordination Supervisor at AgeWell, which is one of the 5 AAAs that Mary mentioned. So what I asked for of SHIP staff throughout the state was just some stories about experiences with people who either just missed qualifying for the Medicare Savings Program or maybe did qualify and how that impacted their circumstances. So I'll go ahead and get into it. So from our SHIP coordinator in Southwestern Vermont, I've got 2 stories from Rutland and Arlington. From Arlington, her husband passed away last spring and her income changed. And she just got a notice that she will no longer qualify for MSP. Her monthly income is just $90 over the MSP limit for one person. Paying her Medicare premium each month will be a very hardship for her. I said I would pass her story along in hopes we see a change in the income requirements for the MSP program in the future. So in Rutland, 74-year-old caller from Rutland yesterday who received a letter that his income was too high to qualify for the MSP program. He still does have VFARM. I screened him for MSP, and his Social Security and pension were $21 over the income limit. Painful. I asked him if he could take his pension in a different way, and he said that he had asked about that, and monthly was the only way he was able to get it. The monthly Part B premium is 10% of his total monthly income. That is significant. I did suggest he fill out an out-of-pocket medical expense form and use that Medicare premium to see if he could get an increase in his 3-square benefit. The MSP income level guidelines are so much lower than VFARM, seems they could mirror each other. From Central Vermont, our coordinator there in Barrie, I wanted to tell you about a client who is 90 years old who came to us when he had his first cardiac event in December. He was prescribed one of the very expensive heart medications and could not afford it. And looking at his coverage, he did not have a Part D plan, as he was told years ago by a pharmacist that he didn't need it. I did a home visit with him and his wife and signed them up with VFARM through the state of Vermont, and he and his wife both qualify for SLIMB, which was a huge welcome to them. Their income was pretty low. They were living in a family home in Waterbury that was old and had high costs for upkeep. When I told them they could each keep $174 in their Social Security check, it was as if they had won the lottery. They were both thrilled. He was also thrilled when he went to pick up his prescription and it cost him $1. That's VFARM. It's the copay from VFARM. So here is one from a client in Franklin County in Franklin. He just turned 65 in October and didn't know he needed other coverage. His wife is on SSDI, so Social Security Disability, and with his Social Security income, around $1,800 monthly, no savings or resource. He is a colon cancer patient, so he needs durable medical equipment and treatment and such all the time. He loses MCA Medicaid, which covered all of that, and he may not qualify for the MSP program. He may not be able to afford a gap, so if he qualified for Quimby, that would be a huge help. Here is another one from Chittenden County. Couple gross monthly income $145 above MSP limits. Clients unable to afford supplemental insurance have decided to apply for financial assistance programs available at the hospital and primary care physician's office to help with medical costs. Here's a client in Colchester, single gross monthly income $245 above Medicare Savings Program limits. Client purchased a supplement due to cancer diagnosis and anticipated high medical costs. This impacted other parts of clients' life and finances, grocery budgets, funds for housing, and car repairs. And I think I'll read one more. So a couple in South Burlington, unearned income below MSP income guidelines. One beneficiary works part-time to pay for housing and grocery bills, ineligible for MSPs due to the earned income, unable to afford a supplement, have elected to get a cheap $0 monthly premium Advantage plan, which may not meet their needs. So that's just a few stories for folks who are, sort of in this gap, I guess you would say, this sort of income gap.
Great, thank you. Any questions? Sorry, I was not here for it. I will watch it on YouTube. Great, thank you, Mary and Sam. Appreciate your testimony. Now we have Meg. Come on up.
Thank you all for ordering snow the day I was slippery driving down. So hopefully you'll all make it home safely tonight. I've been looking at your pot. That's lovely.
Wasn't very well.
So thank you for having me here today. My name is Meg Polite, and I'm the policy director for the Vermont chapter of the Alzheimer's Association. And we're very proud to be part of a strong coalition that's advocating for the healthcare needs of low-income older Vermonters, and you saw them listed before. And you've also heard from many of my colleagues, and I'm sure you'll continue to hear today, stories about how expansion of the Medicare Savings Program will impact seniors in our state. So I do work closely with my counterparts in Maine and Massachusetts who have passed these bills. And we talk about how increasing the eligibility limit amongst our demographic is resulting in more access to healthcare for those who need it. And I want to come today to share why increasing this limit as proposed in Section 9 of H 721 is important to the demographic that I represent, and sort of add on to the pictures that Sam was starting to paint to you to give you a little reality of what it looks like on the ground. So in 2020, there were 13,000 Vermonters over the age of 65 who were diagnosed with Alzheimer's, and that number's projected to be 17,000 by next year, which is a 30.8% increase. The number of Vermonters with dementia is even higher if you include those who are misdiagnosed or undiagnosed, or those with younger onset, meaning they were diagnosed before the age of 65. Vermont's demographic shifts predict the number of Alzheimer's and other dementia will continue to rise. In 2021, nearly 100,000 Vermonters, or 50%, were over 60 years old, 9% were over 70, and 4% were over 80. After the age of 65, the risk of Alzheimer's doubles every 5 years. Vermonters with dementia usually require a caregiver, and data from our 2021 Behavioral Risk Factor Surveillance System, or BRIFIS, report shows that more than 16% of Vermont's dementia caregivers are a partner or spouse, and 44.5% are a child or child-in-law. 71% of dementia caregivers are female. 32.4% are over the age of 65, and almost 60% are over 55. 24% of the dementia caregivers spend more than 40 hours a week providing care. 28% spend 9 to 39 hours, and 48% spend up to 8 hours. So I'm sharing these numbers because they're going to attach to the two stories I'm about to tell you and highlight the needs and the ways that the expansion of this proposal are needed by Vermonters. And there's two scenarios that I hear most frequently about where I think this would have an impact. The first is for a couple. Alzheimer's and other dementias are brain disorders that get progressively worse over time. On average, a person with Alzheimer's lives 4 to 8 years after diagnosis, but they can live as long as 20 years, depending on other factors. The long duration of this disease has a significant impact on a couple's finances, savings, and retirement. According to the American Journal of Managed Care, in an article, The Economic and Societal Burden of Alzheimer's Disease, Managed Care Considerations from September of 2022, the total lifetime cost of care for a patient with dementia is estimated at $412,936, with 70% of these costs borne by the family caregivers in the form of unpaid caregiving and out-of-pocket expenses for items ranging from home health support to medications. So even couples that come into this with robust savings often find themselves out of resources because they're forced to spend down and spend down and spend down until they can access programs. Expanding eligibility for Medicare savings programs would help them stretch their final dollars, and it would provide a small safety net for the surviving spouse who can often live for many, many years after their loved one has died. You've already heard from Mike and Emma about the story collection project compiled by Vermont Legal Aid, and I do encourage you to check it out. It's very compelling, and it really highlights some of the key data points that this bill will address. One of their featured testimonials is from Pamela, whose husband had dementia. Through Pamela's story, you'll understand how dementia impacts both spouses and the struggle the surviving spouse faces. Access to affordable health care and prescription drug coverage is especially important to my demographic because more than 60% of Vermont's dementia caregivers have their own chronic health conditions. I want to highlight the large financial burden of caring for someone with dementia and the impact of that reality. In 2021, caregivers spent approximately $12,400 on out-of-pocket expenses for the person with dementia. And that's about twice as much as someone who was caring for someone without dementia would spend. 4 in 10 caregivers indicated the food they bought just didn't last. 3 in 10 reported eating less because of care-related costs. Expansions of these eligibility limits will have a real impact on the health and well-being of Vermonters. The second scenario that I hear a lot about reflects the economic impact that women face due to caregiving. As I mentioned, more than 71% of dementia caregivers are female. And I believe I said over 40% our children or children-in-law. So we can kind of look in that window right there. Caregivers for those with Alzheimer's and dementia face unique challenges and are often managing multiple conditions. 1 in 4 caregivers spends more than 40 hours a week on caregiving responsibilities. That's a Vermont number. Obviously, this has an impact on one's ability to work. 57% reported sometimes needing to go in late or leave early due to care responsibilities. 18% reduced their work hours, and 9% gave up working entirely. You've heard how this impacts wages over time, and this doesn't take into account situations like when somebody doesn't apply for a promotion because they know they just can't handle anymore, or is overlooked because their upper management can see they don't have the capacity. So caregiving impacts wages. It impacts retirement, promotions, and even the ability to remain employed. The result of caregiving can mean lower earnings and therefore lower Social Security payments and smaller retirement savings. Expanding the eligibility for the Medicare Savings Program will have a significant impact on those who have sacrificed their earning potential to care for a loved one, and it will help ensure older women have access to the affordable health care they require. I'll just close by saying that Alzheimer's is one of the most expensive diseases for our government, our state, and for families. That's one of the reasons why here in Vermont, we're working so hard to increase awareness and educate providers and the public about modifiable risk factors, early detection, diagnosis, et cetera, because we know that prevention is the most cost-effective option. When individuals can't afford health care, they purposely avoid seeing a doctor. This often results in poor health outcomes and the need for more expensive care. Expanding eligibility limits for low-income older Vermonters is one tangible action that can help them access the health care they deserve and ensure they age well in our state. Thank you.
Any questions? Numbers.
Thank you very much, and thank you for considering this.
Thank you.
Devin, I saw you pop up. Are you okay if we take a 10